our topic is angina pectoris. There is stable angina, unstable angina, and then we discuss with MI. In stable angina, the pain goes away or relieved by rest. In unstable angina, pain does not relieve on rest. In MI, there is myocardial infarction. There is no ECG change in unstable angina, and ECG changes are present in unstable angina. In unstable angina, there is ST segment depression, and in MI, there is a segment elevation. And in unstable angina, there is no cardiac enzyme changes. So let's start with angina pectoris. Smoking, patient present with smoking, pain behind breast bone, radiation to the jaw, left arm, pain on exertion, relief by taking rest. Stable angina is the most common cause is atherosclerosis, central chest pain, breathlessness precipitated by exertion, relief by rest or nitroglycerin, history of diabetes, hypertension, smoking. Then there is prince metal angina, we discussed later. Then there is transient pain in stable angina, imbalance between myocardial oxygen supply and demand, causes atherosclerosis, aortic valve disease, hypertrophic cardiomyopathy, vasculitis, coronary spasm, and aortic stenosis. Clinical feature is transient chest pain, relief by rest, nitroglycerin, loss less than 10 to 15 minutes. Ischemic pain does not change with breathing or body position. It changes in with body position, orthopnea, in heart failure. No chest wall tenderness. Then there is a classification of CCS, Canadian Cardiovascular Society, class 1, 2, 3, 4. Class 1 include strenuous physical activity. Class 2, there is angina with strenuous physical activity. Class 2 with vigorous physical activity. And class 3 is everyday activities, and angina with everyday activities. And class 4 is inability to perform any activity. Then there is the features or characteristic features of angina includes constricting discomfort in center of chest or radiation to the neck, shoulder, jaw, or arms. Then there is precipitated by physical exertion and relief by rest or nitrates within 5 minutes. Classification: typical angina includes all three features. Atypical angina include two features. Non-anginal chest pain include one or no feature. Then there is nice classification. It includes possible angina and non-anginal chest pain. Then we will move to we will discuss metal angina and syndrome X later. Then we will move to an investigation. Then the investigation include we do investigations in cardiology. The general investigation include ECG. ECG would be exercise or ambulatory. Then cardiac biomarkers, troponin and BNP. Chest X-ray, we saw on chest X-ray heart size, chambers, pericardium, lung fields. Then we do echocardiography, transthoracic, Doppler, transesophageal, and stress. Stress we give by anaerobic drug, dobutamine beta agonist. Then there is CT scan, MRI, cardiac catheterization, and angiography. In angina, we also do thallium scan, reversible ischemia. It tells about reversible ischemia, irreversible ischemia. Irreversible ischemia perfusion defect during stress but not at rest. Irreversible perfusion defect during rest. Then there is management. Management include lifestyle modification, do not smoke, weight reduction, exercise, BP control, and do not vigorous exercise after a heavy meal, and then take statins, take less amount of saturated fat, and sublingual nitrates take undertaking exertion maybe induce angina. Then standard of care includes the drugs that improve mortality are aspirin and statins, and drugs that relieve angina, beta blockers, nitrates, calcium channel blockers, ranolazine. Then we discuss anti-anginal drug therapy, nitrates, then beta blockers, then calcium channel antagonists, potassium channel activators, nicorandil, IF channel antagonist, ivabradine. IF channel is present on SA node, decreases heart rate. Then ranolazine inhibit the late inward sodium current. We do pharmacotherapy for vasodilations, which include nitrates and calcium channel blocker, and decrease oxygen demand, which includes beta blockers and IF channel antagonist. Then there is non-pharmacological treatment include PCI and cabbage. PCI is percutaneous coronary intervention, and there is coronary artery bypass grafting. We do PCI with sirolimus and paclitaxel, and that's it for angina pectoris.